right, can you hear me okay? Good, I can hear myself, so I figure you can. Well, thank you. I got to sit in, first I admire you all, this is a long day. I was sitting in the back and I was like, holy smokes, I don't know much. It's impressive about testosterone, high T, low T. Yeah, it's incredible, and all the different, how advanced heart failures change. In my day, it was, you never gave a beta blocker, now you do, and it's, I don't know, it tells how old I am. So thank you, this is really a treat for me to be here. I wanted to try to put together something that was really clinically oriented. I specialize in B-cell malignancies, so lymphoproliferative disorders. And in my career, multiple times a year, I'd get a young person who'd come to me with adenopathy. And he or she would have been with that adenopathy for a year, and they'd be getting a year's worth of antibiotics and then a year's worth of steroids. And lo and behold, they had lymphoma. Now, they came and saw me because I treated lymphoma. And it got me thinking, well, you know, there's really not a lot of literature on how do you manage lymphoma patients. How do you look for cancer? Every day you guys have people come in and there's an incidentaloma on a scan or an image, and how is that dealt with? So what I wanted to try to do is make this clinically applicable. Now you'll notice in yours, the slides are moved around a little bit, and there's a lot of slides. A lot of that is just for your reference. I figure when you leave here, you're not going to have that. You're not going to be like, aha, that was the 6th slide on what we do with a small lymph node in the mental area. So it's more for your reference as you leave. So we're going to really focus on lymphadenopathy predominantly. Also talk about what happens with lung nodules. Last year we talked about screening for lung nodules. But what do you do when you have somebody? Most of them are just incidentally found. I go in, I have a cough, I get a chest x-ray, what do you do? And then the bane of our existence. So GI docs have their chronic abdominal pain. GYNs have chronic pelvic pain. And hematologists, we have splenic lesions. And we're going to touch on that. What do you do with that? When do you have to be worried and when do you not? So we'll be going fairly quickly. Because this is clinically applicable, I think we just need to understand cancer is a big issue. Obviously, a lot of what you do when you get images, blood tests, one of the fears we have is cancer. So when we heard Dr. Rao talk about testosterone, when I'm listening to it, I'm thinking, well, what if they have prostate cancer? Can it help them get prostate cancer? If they have a small amount, does it make it worse? Right? Because we're worried about cancer. And that's a big thing. 1 in 2 men, 1 in 3 women will get cancer in a lifetime, and it's a profound cost. This slide really just tells you that what we do is all about averages, right? It's all about relative risk. That's all we do. And so if I go to a convent, I'm pretty confident I'm not going to find prostate cancer unless it's me there, right? You're just not going to find that. And it's okay to laugh. I know you laughed at Dr. McCants, but so I look at these things as I go forward and what is likely to be that diagnosis. And nowadays for head and neck lesions, as we talk about, people with HPV infection is about 50% of head and neck cancers, and that has significance in how we manage that and what I'm looking at when I see a patient, and we'll talk about some of that. So you all know this, but how do we diagnose? This is something that happens when you see a patient and they're like, well, what are you going to do? And well, there's obviously you can do a fine needle aspirate. Just a peripheral smear of a CBC is important. This lesion right in the middle here is a lymphoma cell. It's follicular lymphoma. They call it a buttock cell because it looks like somebody's bottom. But I would look at that and I'd say, oh, there's a lymphoma cell, and somebody else who doesn't may not see that. So CBC is a very powerful tool. Doing core biopsy, and we'll talk about that. That is really important. And then bone marrow biopsies, we do them all the time when somebody has adenopathy. How do we go without, so we can get the best diagnosis possible? And then molecular studies. And this gets a little esoteric, but this is an important tool that we have now and helps us really delineate. When I first trained, there was a small number of lymphomas. Now we've kind of figured out because of molecular tests that there's 50 plus, and it's growing every year, of B-cell lymphomas. And what does that mean? So having the ability to test smaller tissue samples and get molecular answers will give us better answers. And then imaging, you know this, you have somebody comes in and they're ow, my arm hurts or my leg hurts, and they have this lesion. You say, well, that's not good. You're right, that makes it easy. That's the oncologist's way for not good. And then CT scans and PET scans, and PET CT is an important tool. And when do you do it and when you're not? Insurance companies will probably fight every single PET scan you'll ever order because they do me, and I do cancer for a living. So how do we? What's the right place to put it in that has evidence-based? So how do we approach these patients? Oftentimes, people will come in and they'll say, what is this? You say, how long have you had it? Does it hurt? We'll go through the history. Again, when I trained, my mentor, Yancey Phillips, said, 90% of your patients are going to come in, they're going to tell you what's wrong with them. They're going to tell you what the disease is, and that's the history. We've kind of lost some of that with the EMR, right? The history is this long thing that other people put in, and we auto-populate in, hist, whatever. But it's actually okay to talk to the patient and ask them the questions about these things. So what's lymphadenopathy? You either have a big lymph node, you have increased number, or they have weird consistency. Now, I'll warn you now, it's just like with a breast mass. There's old wives' tales that if it's mobile and free and soft, it's okay, you're good to go. That's not the case necessarily. It can be. Tends to be when you have nodes that are hard, firm, and fixed is probably bad. Oftentimes, painful nodes, it just really speaks to the rapidity of how it grows. Now, I don't expect anyone to memorize this list. I actually keep this list in my top drawer when somebody's adenopathy, and it's in your slides. But this is all the different ways that people can get lymphadenopathy. And I can tell you in my life, I've had cat scratch fever, I've had EBV, I've had every little thing that somebody could come in for, sarcoid, et cetera, and cancer. And this list has never failed me. So I try to break it down into big groups: infection, cancer, autoimmune, drugs. Again, that's one of those things you learn in med school, right? And in your AP, nurse practitioner and PA training, is that if they're on meds, always put in the back of your mind, it could be meds, and we'll talk about that. But this is when somebody comes in, this is the kind of the homunculus of the diagnosis. Most common cause of lymphadenopathy is unknown. And that's because most of them go away. Right? As my mom would say, Joey, give them the tincture of time. Well, that's it. You don't want to give too much time, but to give them some time, let them go, because oftentimes it is an infection. Maybe it's a subacute infection that you're not aware of. Then on infection, because they come in, I'm coughing up something, I've got snot running down my face, I've got, what's this rash on my skin, and that helps you think about infection. Then autoimmune, and that's an important thing, and then cancer. And if you look at it, really, of the patients that show up to a family practitioner's office, it's estimated about 1% actually have malignancy. And those that get referred on to a physician, that's 17%. Now, that's obviously surveillance bias, and you may think, what's happening to the other 83%? But that's that are going specifically for lymphadenopathy. The body's incredible. So if you look, we break it down into localized and generalized adenopathy. Most of the adenopathy is in the head and neck region, which we can palpate. The other areas in the axilla, the inguinal area, et cetera, you can palpate the epitrochlear areas. Now, I will tell you, in my life, there's many patients that have come to see me for lymphoma, or they've seen me for adenopathy, and I do a full lymph node exam, feel their spleen, I'm reaching their armpits, they're like, what are you doing? I'm like, oh, I'm examining you. And it's like, it was the first time that they've ever, so, when somebody has adenopathy, we got to examine all the lymphoid areas. And not forget that. And a good splenic exam as well, because that gives you a lot of information. Much of the time, you can actually come up with a pretty good differential just with what God put on the end of our arms and examine people. There's a number of things, and this is, so I won't touch on all of them, but really there's things that pretend to a higher level of risk for malignancy, and you can see them here. I will say that as you look here, really duration greater than 2 weeks, that should pique your curiosity. When somebody has it, it's persistent. Now, there's something when we get a little more subtle in some of the low-grade lymphomas. If I'm thinking you can put that into play, those things can be around for a long time and not really cause a problem. So you're not really at risk. But when something's changing drastically and is there, something should be done, and we'll tell you what needs to be done. In the history, really, you're just looking at how long they've been there, what other symptoms do they have? And I really go into all of them. Are they sexually active? Have they traveled? Is there any other discharges? Are there anyone else sick in your household? What was going on 2 weeks ago? It's not necessarily what's happening today, because oftentimes people don't know that they have adenopathy. So what's happened over the last weeks? Any fevers, night sweats, weight loss. And I've had people going, oh my God, I've lost weight. And I said, yes, forgetting that you had your stomach stapled, have you had any other weight loss? And really narrowing it down for them, because they listen to us. Fatigue, and you heard Ganesh talking about fatigue and low T. There's a lot of, I'm fatigued right now. So I don't, we all have fatigue, but really delineating that out, is it really knocking you back and causing problems? And then do you have any other occupational risks? I talked about drugs. This is a list of drugs. You have them. But that's something that I always try to look for. Really, when I'm looking at anything in my differential, if they're on a lot of meds, medications. So think about that. And if you start going down this list and you go, geez, there's not a lot of reasons for it. It's smallish, and you're on these meds. Well, I can switch you to another med or not. But just have that in your mindset that it could be that. So this is how I evaluate lymphadenopathy. And we'll talk about size in a minute when we talk about imaging, but basically the physical exam. I want to know where it's located. I want to see, can I palpate that? Again, thanks to my days many, many years ago doing GYN where you're delivering babies and I know my finger is 2 centimeters. So that's what I kind of use to determine how big a lymph node is. When you start getting under a centimeter, you should feel better. We call that a ditzel. I don't know if that's a Yiddish word, but it's a ditzel that we say, oh, it's a ditzel, it's okay, we'll watch it. But that's an important marker for size. Then laboratory tests. CBC, every street corner. I do use that a lot. I'm a hematologist. That is, I have a hammer, that's the nail. But that's what we do look at. Liver enzymes, LDH. Then looking for TB, making sure that, because a lot of these symptoms cross over, right? Fatigue, night sweats, weight loss, etc. RPR-ANA, again, looking at other possibilities for autoimmune. And then the easy thing is, if I'm worried, especially above the diaphragm, a chest x-ray. Make sure that I'm not missing something. I do that, and somebody has a wide mediastinum, somebody has pneumonia, somebody has some other pathology, I'm able to figure that out pretty easily. And then the thing that's a key thing, any history of a prior malignancy. In fact, that probably should have been my first slide, because that is something you want to ask right up front. Because for whether it's a lung nodule, splenic lesions, adenopathy, that portends to one of the greatest things as far as what you can do to figure out what's going on with the patient. We've all had any sweats. Oh my gosh, yes. I was jogging the other day and I sweat profusely and it was 96 and what do I do? I'm like, that was normal. If you don't do that, you explode when you're running. So it's okay to sweat. But then you explain drenching night sweats, where you wake up and you literally can wring out your clothes. That's what we're talking about, night sweats. And the weight loss, you're talking about greater than 10% of their weight over 6 months. Because everyone has waxes and wanes in their weight. You're trying to really give definitive answer for whether or not they have the B symptoms. Fever, pain. With lymphoma, many people can have fever. So your fever with other symptoms is an important thing. And that's what you want to look towards. Now, I can tell you, this young guy here, I can't go down an elevator without noticing lymph nodes. And I do that all the time. It's wrong, but I look and, you see that. And it's, be thankful I'm not a urologist, I guess. But, so I'll notice, I'm always, should I say something? Well, that looks under a centimeter, so, but you'd be surprised how many people come. I once had a young lady aerovac'd in from an outside hospital who had massive adenopathy, and she basically had EBV infection. They thought she was done, and all the mascaras on everyone's cheeks, crying, oh, she's going to, and it was EBV. We sent her home, gave her some steroids, and she was fine. And so doing that history, it literally took about 15 minutes to sort through that. Knowing this, and this is in your notes, but knowing this, what nodes come from where, is vital. When I do a lymph node exam and I feel lymph nodes, I will go and use this map to then go and say, okay, if these are submandibular nodes, I'm going to look inside the cheek, the lower lip, gums, and the tongue. I'm going to do a close look at that, because it's really you're just taking something from upstream that's coming to there. That's all. Lymph nodes are just these little filters. So by having this in my brain, I really can help a lot and figure out to rule out other causes. And especially in the head and neck, where in Kentucky, where the #1 prevalence of tobacco use in the country, that's an important thing. So you have a lot of head and neck cancer from that. Obviously, with the fastest growing cancer in adults is head and neck from HPV and that whole thing, although if we get everyone immunized from HPV, we should eradicate that. But use this. And then again in the trunk, so infraclavicular, supraclavicular, axillary. If you have a woman who has axillary lymph nodes, you're really duty-bound to do a breast exam. If you don't, that goes under the lawyers put that under not good. So you should do that. Epitrochlear, look at their hands. I've had people that in the summer they work with roses and they're getting their fingers stuck constantly, so they're getting these microinoculums of bacteria, and they get these adenopathy in the epitrochlear. So look at that. Think about what they're doing in that area. Now the supraclavicular, this was on all of our training when we were younger. There's like, if you have a left supraclavicular node, what's that called? And it's Virchow's node, and you felt all proud because now we've sprung it on the next generation of residents and students, and et cetera. But if you have a left supraclavicular node, you need to do a good abdominal exam. You just need to, because that's where the pathology drains up to there. If you do have left supraclavicular nodes, that portends to a greater risk of having a malignancy, and you need to know that. So I am very vigilant. When somebody comes in and it's above the clavicle, I do a very thorough exam of the abdominal area to make sure there's not some type of pathology that I can identify. And then the inguinal area. Now the inguinal area is difficult because if you look from the drainage from our feet up, like I'm sure your feet are all fine, but mine are awful. So they're in shoes all day, and you get a lot of inflammation and stuff. So you get adenopathy. On most people, I can find a lot of shoddy lymph nodes in the inguinal area. So you got to be careful. So you tend to, as we'll talk about, go for greater size. But this also gives you a map of what you should be thinking of if they do have inguinal adenopathy. Imaging, I'm not going to spend a lot of time. You all do imaging every day. As I told you, I get a chest x-ray as kind of a quick if I need, just to make sure there's not something else going on. And then really the CT is the gold standard for lymphadenopathy, and that's what you should do. PET scan, we'll talk about its role. I know probably some of you have used gallium scans. They're really not used anymore, but they were really and especially in Hodgkin's disease, was a staple in the past. So as you look at your CT scan, we were talking a few minutes ago about the CT reports, and you literally have to be a lawyer to be able to read CT scan reports now, right? They're talking about, in the right scenario, I would do this and this, right? It's not a diagnostic test. It literally just shows you an image against a plate, right? That's all you're showing is the size of a node. But we know if the nodes are under a centimeter and it's one lymph node, you're probably okay. It'd be somebody I'd watch, have them come back in, but they're okay. If you see central necrosis, that's more likely to have cancer. Because what ends up happening is as cancer grows, it outstrips its blood supply and the cells die. And some of the tumors cause angiogenesis or neovascularization, and they do fine, but typically you'll see that happen. When you start looking at when there's more than a couple lymph nodes, then you just got to start just wondering if there are other things that make you think about cancer. Now, this isn't definitive. You're just trying to point in a direction. What do I do next? Really, the gold standard is you're trying to find out who do I send for a biopsy and who do I not. So ultrasound is something that's easy. I like the role of ultrasound really for when you're trying to find a deep lymph node in the clinic, and they can quickly put it on there so you're actually able to do a biopsy in the clinic. It helps you find the node. The one pearl I'll give you, if you ever send somebody for a breast mass, lymphadenopathy, pick your mass that you see, and they come back normal tissue, stop, repeat that biopsy. Because nothing should be normal. It should be adenoma, it should be reactive hyperplasia, it should be infectious, whatever those things are. So that put in the back of your mind, I've seen more patients in my day that have come in and they're feeling great and they're told, hey, the biopsy was normal, nothing to worry about, and they bought the boat that says live forever, and they end up having metastatic cancer. So really take that to heart. If you're looking at ultrasounds, and you probably don't, the peripheral vascularity actually portends to more likely having malignancy. Then the PET scan, what do we use PET scan for? And that's really a tricky thing. PET scan, right? PET scan is you're just taking a radiolabeled sugar, and something that's metabolically active will preferentially take up the sugar for energy. Well, A lot of these cancers are indolent, they're slow growing, and they tend to not show up on PET scans. So if you do get a PET scan, don't think like problem solved, it's negative, because if it's not the right disease, it will be negative. So the bottom line is, as my pathology friends would say, tissue is the issue, Joe. Two things. If you're going after inguinal or axillary, I tend to think 2 centimeters or greater, because there's a lot of things that can cause those to be inflamed. I do watch them, and if I'm going after them, I'll do an excisional biopsy, not just a fine needle aspirate. Fine needle aspiration, oncologists like me, we had this long history of bias against them, and I'll talk about that, but it's because there's a relatively high false negative rate, and in lymphoma, which is really what you're trying to show, showing a solid tumor is actually pretty easy by fine needle aspiration. So if it's a lesion you think it's a solid tumor, that's a great study. Low false positivity, so if it says there's cancer there, there's cancer there, because you're getting a small sample and you're getting cancer there. It's cheap, it's easy to do. So I do these. That's something I say, if we have a positive test while we're waiting to do some of these other things, we can actually direct what we're going to do going forward. Looking from our world, if you'll see here, there's actually, looking at in lymphoma, you do fine needle aspirate with flow cytometry. There's actually, when you're positive, there's actually good specificity and sensitivity. It's just when you start getting for negative predictive value, it's really bad. So again, I did it. I got some cells. I even got lymphoid tissue, and it's negative. That doesn't mean it's negative. You still need to go forward. This is a study we all rely on, and I would sit in tumor boards and everyone would stroke the gray beard and say, well, we can't do FNA because we have this study from JCO and it shows that it's, most people it's not good for, and blah, 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 blah. But it actually, there's other data showing that it is. With the addition of flow cytometry, and we happen to have amazing cytopathology at Norton. So having great cytopathology, a fine needle aspirate is a fine way to start. And if you get the answer that it's positive, then you can actually go down to therapeutic modality. So as I said, it's best to confirm a malignancy. If somebody's had cancer before, you want to show recurrence, or if you're showing a solid tumor versus a blood cancer like lymphoma, that's fine needle aspirate's really good. If you know that the people are really good, and we actually have an evaluation diagnosis clinic, so if you have somebody here, they'll do all this for you. So it's just the evaluation diagnosis clinic. And so if you have somebody, they'll go through all these maneuvers. Core biopsy is really just, it increases your sensitivity from 82% to 93%. It gives you more tissue. It helps us because if we have to do immunostains, there's more tissue to do that. And then this is the gold standard, excisional biopsy. So I know everyone knows this. Excisional, you take the whole node. Incisional, you take part of the node. Incisional is good for big lymph nodes that are deep. So you're taking part of the lymph node, or for people that may not be able to undergo a big whack. So it's having that in your back pocket. And then again, that's where you're balancing out for incisional versus doing a core biopsy. And really in summary for this, lymph nodes greater than 4 centimeters, they need to be biopsied, plain and simple. There's nothing good. They may be benign still, but likely this is going to be cancer. Now, you'll see a lot of young people, 20-year-olds, 19-year-olds, they get adenopathy all the time. Don't make the mistake of giving long-term antibiotics. Don't give steroids. Watch them. If after 7 to 14 days they're still present, then you need to do something about it. Hodgkin's, aggressive lymphomas are common in that age group. You have these in your handout, so hopefully this will give you a little map of how do I best follow down along that. So I'm going to jump to solitary pulmonary nodules, and this, we've talked in the past about screening, so this is a little bit different. These are those patients that you go along and they have a nodule. And a solitary, single means solitary, and then they're usually less than 3 centimeters. Anything over that, we call it a mass. So as you're talking about it, you have a solitary nodule versus having a mass. They're well circumscribed, and they have lung parenchyma around them. We do look to see if they're solid or semi-solid. And this is an example you see here. And you've probably seen those, but that's the classic look to them. Again, the history is important. So if you go through that and you ask all those questions, you want to find out clinical features. Were they a smoker? Did they have history of cancer, which is the most important? Because if they did, and this shows that the lung is a metastatic location for rectal cancer, for breast cancer, for any number of GI cancers, and again, internal metastasis from lung itself, lymphoma, etc. asbestos exposure, etc. Is the lesion in the upper part of the lung versus the lower? Upper part has a higher propensity to be malignant. And then now you're going to start looking at imaging. You already had, whether you had, this is obviously a CT scan, the image before this, but then what are the other modalities you can do? Looking at the differential, cancer, infection, autoimmune are the biggies. So you want to make sure they don't have something that drives you in one direction or another. But if they have a long history of smoking, you're really duty-bound to make sure they don't have cancer. This gives us a kind of an idea of what the increased risk is for these patients. If the nodule has a wall thickness of greater than 1.6 centimeters, it has a marked increased likelihood of being malignant. If they have a size greater than 3 centimeters, if the SUV of the PET scan is greater than 2.5, and the higher it is, the more likely. If somebody has a PET scan that has SUVs of 10, the likelihood that that's cancer is something like 87%. So you want to look for that. Now, infection can be high as well in the acute phase, but that's going to make you worry a little bit more. Age, if there's margins that are different, if they're active smoker, et cetera, you can see that here. But the other thing that don't lose sight of this is the growth pattern. And what that means is if I have something that today I see, in a year it's the same size, and a year later it's the same size, it's not cancer. Now, could they develop cancer there? Yes, but that's not cancer. Cancer knows, we say cancer don't know it's Christmas, meaning cancer just grows. Right? Cancer is just abnormal cell growth. Either grows fast or it grows funny, but it grows. So if that's been the same, you're pretty good to not have to worry about that further. This is in your chart, and it gives you kind of how do you figure the probability of malignancy. And I think, as you see on the right here, if they're older, if they're a heavy smoker, prior cancer, larger size, margins are spiculated, and it's upper lobe, they're more likely. The probability can be over 65%. And that will really drive how you do your further workup of these patients. This speaks to the size. When you start getting over the 3 centimeters, the likelihood of malignancy continues to climb. That distance from 2 centimeters to 3, there is an increase over below that, but it's certainly something you worry about. This, again, just shows if you have something that's under 4 millimeters, and Renee and I were talking before, somebody under 4 millimeters, the likelihood is less than 1% that it's malignant. It's not 0, it's under 1%. So you're really probably okay when you're looking at those patients to make sure you don't have to be too belligerent in your workup. Other nodal features that you can see, and everyone talks about this, the only thing I want you to focus on here is that if your lesion doesn't double in that year, the likelihood of malignancy goes way down. So it doesn't double in a year in size, likelihood is far less. And then the shape, and there's all kinds of different shapes, and these are just rules of thumb, but they're really, I wouldn't hold it to anything other than if it's the size is over 3 centimeters, worry about it. Chest x-ray, the best chest x-ray is the last chest x-ray. To let you know if it was there before or not, is it new, if it's stable, if you're looking at whether it's part solid, if it's less than 8 millimeters or not, it will tell you when to surveil, and that's in your notes as well. PET scan, people who get PET scans, somebody who has a nodule greater than 8 millimeter with a low to medium probability, nodules 1 centimeter or greater. You start getting under a centimeter, you're going to have a lot of false negatives. And then it has good sensitivity, but specificity is not good. So having it negative or having it positive, you don't really know what you've got. All you know is to go after it. Who should have serial scans? If you're in the very low probability, so there's people, the young people, no smoking, etc., those people. If you're in the medium prognostic realm and your PET is negative, that's somebody you can actually just do serial scans. And if you've done a needle biopsy and the PET is negative, you're better to do serial scans. And then if the patient just says, I don't want anything else, that's probably the next best thing to do. Calcifications in lymph nodes or in nodules is a good thing. So if somebody has popcorn calcifications or central calcifications, that's a good thing. It speaks more likely that it's benign. It's a chronic inflammatory process. It's in the risk of it. Now, some people with malignancy can have calcifications, but it's generally not so. And then who should get the biopsy? If you're high risk, if your PET's positive, if you've had a needle biopsy or you've had a bronch and it shows some concerning cells, or if your CT scans have shown marked growth. take them to biopsy. Don't mess around with that. Now, the problem is a lot of these people are smokers, so you have to balance out your clinical suspicion about how they're going to do during the surgery. And you have these in your notes, but they give you an algorithm you can keep in your desk, so when you have that person, you can just pull that out, and it helps take you the right pathway. So we'll finish with splenic lesions, and this part of the talk is like kissing your cousin. It's not really satisfying. It's, and I don't know your cousins, but if it were mine, it's not. And I've not kissed my cousin either. I just want to make sure that. But we get these all the time. Somebody gets an incidentaloma in the spleen, and what do you do with it? Like, in parts of the world, they'll go, splenic biopsy. Well, we don't do those. So how do we work them up? Well, it depends, again, on the history. It depends on the characteristics of the lesion. If it's solid or cystic, do they have a history of lymphoma? LPD is lymphoproliferative disorder. Are they immunocompromised, HIV, et cetera? You know, that type. Have they been on immunosuppressive agents for autoimmune disorders? And that may make you more suspicious. Have they had other signs and symptoms? Are they Hep C positive? There's a lot of things you want to look at. If you've had prior imaging and you look and it's pretty much stable, great. And then if they've had trauma, you want to look to see, because if it's a hemangioma or if it's blood-filled, that will matter. These are in, I keep saying these are in your notes, and I purposely didn't want to talk this. You didn't need me here to read these charts to you, but these give you kind of something you can put in your pocket to look towards. It helps lead you down a path if people have splenic lesions. So benign lesions are those that are homogeneous, low attenuation. There's really no enhancement, and they have smooth, they're cystic basically. And those still can be malignant, but the likelihood of that is much less. I still look really for lymphadenopathy at that point. I really do a good exam from a lymph node exam to make sure this is not the lymphoma. Because remember, the spleen is a lymphoid producing area. And then if you have heterogeneous enhancement, irregular margins, et cetera, as you can see here, if you have enlargement over time, those are things you need to worry more that there's something else going on besides just it's an infectious process. Now, if it's fungal or there's a lot of infections, you still have to treat, but it lets you know to go down that. Because you're really making the decision, do I take the spleen out or not, is really what it comes down to. Because you're not going to, trying to biopsy this is impossible. So it's a splenectomy. And you got to be pretty confident the person has a malignancy. And this, again, is a graph that gives you an idea of how to proceed. So I'll stop with that and answer any questions. I know I went fast, a lot of slides there, but I want you to have stuff to be able to rely on as you go forward. And I'll stop and answer any questions. And thank you for letting me be here. Questions? Yes. Yeah, it's actually the opposite. We have that's generalized adenopathy, and again, without knowing more about the patient, I would say that could be a lymphoma. There could be other things, but that would be somebody, if they have enlarged lymph nodes that size, I would be more apt to try to take tissue. And there's different ways you can do that, but you know, if you want to talk offline, but there's a lot of different ways to approach that person. But somebody has bilateral enlarged adenopathy. Cancer doesn't know symmetry or asymmetry. It's just, it can grow. Lymphoma, I've had many people with adenopathy everywhere, and you just don't necessarily know what's going on in here. Yeah, what I would say, well, again, understanding that I'm not practicing out of my sphere, that's because it's being taped, and I want the lawyers to know I said that. That you can actually send it with the evaluation diagnosis clinic, and we can talk after lunch, but they can help take them to whatever that next thing may need to be done without knowing all the ins and outs about it. But anyone else? Well, thank you very much.